Good morning, good afternoon, and good evening, everyone, and welcome to the 11th webinar in the Cardiovascular Connections 2022 series. Today's webinar is titled Cardiometabolic Disease Pathophysiology and Novel Therapies for Atherosclerosis and Calcification, featuring Dr. Michael Sturek, Professor of Anatomy, Cell Biology, and Physiology at Indiana University. Today, Michael will review features of macrovascular atherosclerosis and microvascular dysfunction that underlie ischemic events and the need for appropriate animal models for optimal translation. Before we get started, we would just like to acknowledge our partners at the American Physiological Society and the European Council for Cardiovascular Research, and also to thank the sponsors of this webinar series for making it all possible. And now I'm pleased to invite Michael to the floor. Hi, Mike. Thanks for being here today. Take it away whenever you're ready.
Oh, thank you. And I'd like to thank first thank the APS, American Physiological Society, and the European Council for Cardiovascular Research for this invitation to speak in what I think is an outstanding seminar series. And a big thanks to the Inside scientific staff, Sarah McFarland, and especially Sydney Menson for spectacular work on loading the presentation to the webinar platform. I'm trying to address a couple overall questions today. One, how does dysfunctional intracellular calcium signaling in coronary smooth muscle lead to coronary artery calcification? And two, how can we translate this science to cures? And I'll have this outline for us today, and to keep us on the same page here. And I'll start off with talking about obesity and metabolic syndrome. And I guess you have to frame the problem. And this might be the problem if this person was walking around the streets of Indianapolis. He'd be arrested for indecent exposure. But if he was walking around the streets of Indianapolis, he'd probably look more like this. And that is because Indiana is one of the top 10 in the U.S. In terms of obesity, and it's a major problem overall. As the NHANES study has shown that about 66% of U.S. adults are overweight or obese. And obesity is a major driver of metabolic syndrome, which ultimately can lead to type 2 diabetes and complications. And to characterize metabolic syndrome, it's an overall syndrome of a number of characteristics. One, central obesity, insulin resistance, glucose intolerance. Dyslipidemia is shown by an increase LDL to HDL ratio. And dyslipidemia is also quantified by an increase in plasma triglycerides. And then finally, hypertension. And there are a number of position statements over the years that strongly support this overall syndrome, as shown there. So now we have to consider in studying this, what is the normal progression from normal glucose tolerance to insulin resistance or metabolic syndrome, and then on to type 2 diabetes. And so if we look at this graph, we're going to focus on this main kind of time frame here. And if you look at the top panel there, type 2 diabetes is defined as a statistically significant increase in fasting glucose. And that actually doesn't occur in people until about 10 years of development of this prediabetes or metabolic syndrome. And as you can see in the lower panel, during this long period, there's a steadily increasing insulin resistance and a compensatory hyperinsulinemia to try and maintain euglycemia. And there's also beta cell expansion, but then when they start to kind of crash, then that's what gives rise to the increase in fasting glucose. And so, and importantly, comorbidities and complications are ensuing from the very start during prediabetes metabolic syndrome period. And so we take into study this with miniature pigs, which mimic the human disease pretty well. And it's on a different time frame, but it takes about over a year or so of basically a super Western diet to get any type 2 diabetes to occur in them also. But they do have pretty robust insulin resistance, metabolic syndrome, et cetera. And then the pigs that I'm speaking of mainly are going to be Ossabaw miniature pigs. So when they're active and lean, they're they're relatively healthy, inactive, and eating the extreme Western diet. They become obese. And we've been studying these for about 18 years here at IU School of Medicine in Purdue. And then we've transferred the technology to a startup company, Corvus Biomedical. And I'm going to show you several slides here just to reinforce the morbid obesity and so forth, and that. And in this case, Dave Flum at the University of Washington has used these animals to study bariatric surgery. And we should have another. There we go. This is actually video, as you can see. The pig isn't moving really, but because it's obese and fairly lazy actually. But you can see I have difficulty standing on this relatively slick floor. But it must be said that she's at least kind of modest here. So now, despite the obesity, we can put pigs on a treadmill, and this fellow actually gets a nice training effect even at his low workload there, because he was at a 75% of maximum heart rate for a number of days. There should be another video coming, and this is a YUCATAN pig, a lean YUCATAN pig, and this pig's running a lot faster than that obese Ossabaw pig to hit its 75% max heart rate training kind of threshold, and they can go on for 75 minutes or so at a higher intensity than that. So it reinforces the obesity. And so what we did was in this review, an annual review of biomedical engineering, and a direct test of YUCATAN versus Ossabaw pigs to determine which miniature pig model is a good model. And you'll see as I go down through these metabolic syndrome criteria that we see a lot more yeses in the Ossabaw column overall. But the Göttingen pig, which is widely used in Europe, also is an excellent metabolic syndrome model. But I've not seen publications showing whether that they have hypertension, but they are on the metabolic syndrome kind of spectrum, though, compared to the YUCATAN, which is really again a lean pig in our experience. There's variable hyperglycemia to define it as type 2 diabetes, but that does exist in both the Ossabaw and the Göttingen. And for our purposes, we're real pleased that coronary disease is much more significant in the Ossabaw than the Göttingen or YUCATAN. So now, for a swine model of human metabolic syndrome, I was really pleased to see this review by Cluzel et al., in which they did a systematic review of six livestock and 7 miniature swine breed, and the main conclusion was that the Ossabaw miniature swine in particular represents a highly translatable model that develops each of the core parameters of the syndrome with many of the associated secondary comorbidities. So, and I emphasize a couple of things. One, we've never collaborated with this group, so it was good to see an outside opinion on swine models of metabolic syndrome. And two, we're really interested in the comorbidities, like specifically coronary artery disease that I'll talk about today. Should be advancing. There we go. Whoops. Okay, so and to further characterize the overall phenotype of these pigs, we're interested in swine model of human ischemic preconditioning. And preconditioning is defined as a short duration myocardial ischemia and reperfusion that it will attenuate subsequent myocardial infarct size in response to longer duration ischemia. And this has been preconditioning is just about universally shown in swine, but randomized trials in humans have been a bit disappointing and have largely been failures. And so we were wondering how the Ossabaw pig fell. Whoops, shouldn't go that far. Here we go. Okay. Sorry about that. Advanced too far. And so we teamed up with Petra Klein-Bongard's group, and we have this a study in basic research in cardiology that's in press, and we compared it with some of their previous work published in cardiovascular research. And there we go. And so comparing the Göttingen versus the Autobahn, and with the ischemia reperfusion versus ischemic preconditioning, as you can see there in the gray bars, 3 different bouts of short duration ischemia followed by the longer ischemia and reperfusion protocol. And the bottom line of a lot of data, in this was that the Göttingen shows preconditioning by a decrease in the infarct size, but the Autobahn just did not show that at all. And we went on to do genomics and found clusters of differences in protein coding genes between Autobahn and Göttingen in many pigs, and there's several different ones, but the one of most interest to us in this regard was the inflammation in the JAK-STAT signaling pathway. And because it's been shown that the increase in phospho-STAT3 during reperfusion in the Göttingen does not occur in the Autobahn. And in the Göttingen, if you in other pigs, if you block p-STAT3, then that will block preconditioning. So the take-home message is that there's no cardioprotection in the Autobahn, but robust cardioprotection in Göttingen in many pigs. And so based on what I told you previously about the failure in human clinical trials, I'd throw that out there that maybe the Autobahn is closer to the human in this particular regard. So but let's get on to real, I think that's part of the overall phenotype of the Autobahn pig. And now we look at the coronary atherosclerosis, and you can see here that in that square there, or that rectangle, there's a left anterior descending artery, a macrovessel that has extensive atherosclerosis, as shown by those massive, they almost look like snowballs there. But in other areas of the myocardium where the microvessels exist, you don't see that sort of build up to any extent. Even when we zoom in, we can see veins and some artery and some small microvessels coming off of that branch, but they still do not have that amount of atherosclerosis, and that shows up in histological cross sections. But that's all. But here we're back to the conduit arteries. And looking at type 2 fatty streak here and a hematoxylin eosin, there's just a little bit of neointimal hyperplasia compared to the type 6 complex lesion, where we also see calcium. And you can see really nicely in the Verhoeven Giesen stain on top there, in the type 2 fatty streak, the neointima, and then below there in the complex lesion, the calcium is really an intimal calcium calcification, and that really shows up in von Casso, which really stains the phosphorus that's in the extracellular calcification. So, and then, but does this stack up to humans? And so here we have histology from an explanted heart from our transplant program. And we see in the top right there, the neointimal thickening there, and there's a whole spectrum from just a mild thickening to upward in the upper right-hand corner there, some significant intimal hyperplasia. And then the image below that shows lipid and calcification, and then this is also intimal calcification in this particular case. So I think there's pretty good evidence here that these lesions in the Autobahn pig are similar to those in humans. Now we want to image this early atherosclerosis and calcification because it's unstable and it can progress though to stable. And so we can image it. In this case, here's a standard angiogram. And you can see in the left artery, right before that bifurcation, there's a real focal occlusion. And then it can, one can dilate the vessel pharmacologically, and then get rid of that spasm. And I'm not seeing, there's the image. Okay, so again, vasospasm shown at point position number 1 there. And the dilation, and this was dilated by a calcium channel blocker, which suggests that voltage-gated calcium channels have a lot to do with maintaining vessel patency. So one can use angiography to quantify atherosclerosis, but a better way that we use routinely is intravascular ultrasound and also intravascular photoacoustic imaging. And because the advantage there is that it's much more precise. And with photoacoustic imaging, you can see by the red laser there coming out that it actually gives us chemical specificity for lipids in the vascular wall and the perivascular adipose tissue. And then the other thing about these methods are that we can withdraw the catheter and a pull back through the vessel and get cross sections to the vessel so that we can know where there are atherosclerotic lesions and compare to areas where there's very little. And this is an actual real-time image of an intravascular ultrasound imaging, and you can see there now a branch has come in as we progress past that. But look at the calcium and the arrow at the top there, and it's now frozen here appropriately. You can see a nice calcification with an acoustic shadowing peripheral to those calcifications. So those are in areas spotty or not, probably nodular calcification. And so we want to be able to diagnose or image the coronary artery disease progression from healthy to those very complicated lesions. And we know that inflammation is involved in some ways, but more interested in active calcification, which can be measured with sodium fluoride uptake using positron emission tomography, computed tomography, and be able to use those and earlier in the progression before there's a major risk of rupture and cardiac mortality, especially before there's more stable calcium turnover. And for example, in the complicated lesion, one can do a CT scan, and you can get your coronary calcium score that way. But that's already very developed calcification. And I just clicked on up there in the fatty streak, and you see a couple of blue arrows, and also in preatheroma, where calcification is probably occurring at that time. And we know that with intravascular ultrasound, you can image spotty calcification, say in a preatheroma. And but with sodium fluoride PET, active calcification, I will show you, we can even visualize in fatty streaks, and that would really be almost at the molecular calcification stage. So, all right, and so that I'll start to emphasize these points right here. So, and in panel A there, we see basically a perfectly disease-free segment of the artery. And so if you look over at this heart schematic and artery schematic at point A there, that could be where that is. And there's just no intimal thickening whatsoever. You advance it a little bit, or pull it back a little farther. And in this particular case, there's a wall coverage of 100%. That is a thin intimal thickening around the entire circumference of the artery. And drawing back farther, point C then ends up where there's a focal lesion. And in this case, there is plaque burden there, which is represented by the area between the red circle and the blue dot, or excuse me, the yellow dots there. And then we also see those green segments in panel C that are, again, calcification segments that also have the peripheral acoustic shadowing. And then what we've done then too in panel D is plot this over months of atherogenic diet to show how there's this progression, as one might guess, with the percent wall coverage that's plateaus, but plaque burden continues to increase. And one can again image those with with angiography, but intravascular ultrasound is far superior. All right. Now, in early calcification, one can do that with, again, sodium fluoride PET CT, because hydroxyapatite is the extracellular calcium calcification source, and it has calcium, phosphate, and hydroxyl. But in the hydroxyl group is substituted with fluorine at a very high affinity, which makes it a very good indicator. And so, if you brush your teeth this morning, you probably have some fluoride that has now bound to that hydroxyapatite to make it even stronger. And so with one images this, in this case, you can see that the skeleton really lights up because, of course, it has calcification. But if we zoom in to the vasculature and increase the gain, then it's possible to measure calcification in soft tissues like the vasculature. And so early calcification, I'm going to make a case here, again, using this schematic on the right. If we inject radiopaque contrast media through in this case, the left anterior descending artery, and then quantify that signal, and one gets then a relatively linear relationship of that uptake of the sodium fluoride into the wall as a function of the wall coverage, and again, that's being even in just a type 2 lesion. Now, but in histology, yes, we can see some of those microcalcifications, but in this particular case, in this type 2 lesion, this was not statistically significant. Again, arguing for a very sensitive assay of calcification with sodium fluoride PET. So, and then we also looked at the calcium in regions away from the large conduit arteries, and did not find a difference, which indicates that there's no cardiac or microvascular calcification at that particular time. But again, the calcification in the conduits is really early molecular calcification.
Okay, so this is pretty good. Early calcification, I'm going to emphasize that is unstable. And so, and that's because it's microcalcification. So it's kind of spotty, is indicated there in my schematic. And this was shown by ATHERO, where they see in all these arrows here, these are these spotty calcifications, which are just tiny spots instead of a full calcification around there. And that what they found was that the average number of calcium spots by intravascular ultrasound in acute myocardial infarction was 2.8-fold greater than in stable angina patients. And this was associated with fatty plaque, so unstable. Now, the other point I want to make here, though, too, is that then that can progress to nodular calcium, or calcium nodules, and that is a problem therapeutically. So, and it's shown up here, these data by Sugain et al., where in most treatment with a stent, if there are no calcium nodules, you see that the event rate is actually only about 10% over a whole 5-year period. Whereas if there were nodules at that stent site, then those individuals actually have major cardiac events. 50% of them have major cardiac events after only 3 years. And that corresponds with needing a revascularization of that target vessel. So that's not good either, and there's not a treatment for that sort of effect. Now, late calcification might be stable, but and we'll see what that is. In this Van Rosendale study, they showed that basically a high-density calcification, focally, this high-density calcium plaque, which they call 1K plaque. It's 1K because it's 1,000 Hounsfield units of brightness in a CT scan. It's associated with lower risk for future acute coronary syndrome, and that's good in that particular area. But if that high-density plaque extends further in the vessel, then you're going to get increased stiffness and increased pulse wave velocity, which we know will result in microvascular dysfunction. So that's the downside to getting there. And the downside to having calcification overall is even when it's not stable, it's going to be unstable, and there's more complications from that. So I'm going to go through this quickly just to make this point about specificity of micro versus macrovascular disease. And so and here's a schematic of a major conduit artery. You got the metabolic syndrome milieu in there, and I've drawn in maybe an obese smooth muscle cell on the left there to indicate that there's calcium signaling dysfunction going on in there, which we'll get to here later. But the macro and these macro vessels, they're conduits, and largely growth goes on, really growth of vessels and to make those conduits larger. But we know that microvessels, as shown there, and that is actually a pretty decent size comparison. It's about 5% the diameter of a large conduit artery. They're flow regulators, right? They do that by contraction and relaxation of the smooth muscles there. So different functions of these vessels, and they're going to have different a number of other different properties. All right, and one is stiffness, and we collaborated with Aaron Trask on this. And what Aaron found was that the microvascular beta stiffness index actually decreases in metabolic syndrome versus lean pigs. And it is just the opposite in the macrovascular beta stiffness index, which we get from intravascular ultrasound recordings, and in this case, stiffness increases in metabolic syndrome compared to lean. So again, very much different micro versus macro. Ion channels are different, and this is some work done by Doug Bowles some time ago. And the bottom line is, if we just look at the sedentary open symbols there's about a more than a twofold greater voltage-gated calcium channel density in a large arteriole on the right compared to a conduit artery smooth muscle cell. And another example too is, and studying in calcium sparks, which are calcium release events that are represented by spontaneous transient outward currents. And for the sake of time, let's just look at the control there. Basically, what Eric McKelkey found in collaboration with Nelson's group was that there's basically microvessels stocks are tenfold greater frequency than conduit stocks. And so again, the main point is that there's differences between these vessels, which leads to then my this next section on sarcoplasmic reticulum calcium changes that occur over the progression of disease. And so if we look at calcium signaling in healthy coronary smooth muscle, here we just disperse. You see that the vascular wall there, disperse medial smooth muscle cells. They have voltage-gated calcium channels, transient potential receptor channels that allow calcium influx, and extrusion pathways being the plasma membrane calcium ATPase and sodium calcium exchanger. And then in the sarcoplasmic reticulum, there's ryanodine receptors and IP3 receptors, which release calcium, and sequestration is done by the sarcoplasmic reticulum calcium ATPase. And so here's and you kind of saw this previously in some of the data that I showed on atherosclerosis, but this is a design to test whether coronary smooth muscle calcium signal and how it changes over the duration of metabolic syndrome. And here we see, so we compared leans, and I just put a little schematic of a nice healthy artery there, and versus arteries from a metabolic syndrome atherosclerotic animal at about 6 months into the protocol, 9 months, and then 12 months. And so at 12 months, you, of course, going to have more atherosclerosis. And we characterized then transporters over this whole time frame, and did that with FURA2 imaging, disperse single cells, load them with FURA2, image them, and quantify the signals in response to a variety of agents. And so here's a typical calcium signaling protocol where we depolarized with 80 millimolar potassium, shown by that horizontal line, and we get a little bit of calcium influx is shown there, but and then use caffeine, which binds the ryanodine receptor and releases the SR calcium store. Calcium efflux can be quantified also. But then the next, the one we focus on also, though, is circa function, which is quantified by that undershoot after we wash out the caffeine in a zero calcium solution. And I'll show you the schematic to explain several years of work on this and a number of publications, but of this biphasic calcium dysregulation in metabolic syndrome. And so we start off with a certain amount of SR calcium, certain amount of circa, and calcium influx via voltage-gated calcium channels. And these are the ones that we've followed the most closely. Initially, under mild atherosclerosis, is shown here, circa increases, shown by the circa pumps in the SR, and there's an increase in the SR calcium store, and voltage-gated calcium channels increase at that time also, shown by more sort of calcium balls there in the cytoplasm. At the same time, we also, in this very mild atherosclerosis, where you see just at the neointima shown there in that histology, we do see 18F sodium fluoride binding to extracellular hydroxyapatite, and so and associated with that is that this is a proliferative phenotype. As we let it progress, it becomes more of an osteogenic phenotype in the severe atherosclerosis. And in this case, the circa decreases, the SR calcium store is less, and voltage-gated calcium entry decreases. At the same time, the extracellular calcification increases, and that I just put two different calcium and phosphates, the hydroxyapatite with F18 binding to it, and it should be a lot more in this more severe stage. So so that's the pig. That's the coronary artery of the pig. Does it hold up when we compare it in humans? And the short answer is yes. And so what we did was we had explanted hearts from ischemic and non-ischemic patients who were then getting a new good heart in the transplant program. We did histology, dispersed cells, and then imaged them with FURA2, and compared to our metabolic syndrome pigs, lean and fairly severe metabolic syndrome and atherosclerosis, and there is the take-home message of the study, and that is that if you look at the human mild coronary disease there in the purple tracing, they have pretty good calcium influx and the calcium release. Whereas, and which is similar to the our lean swine, but the human with severe CAD, and that's shown by the blue tracing below that, has lower calcium influx, lower calcium release, similar to the swine metabolic syndrome, and shown in the red tracing. And we can look at this in a little bit more detail, though, to appreciate this more. And so on the left here, calcium influx, and we had to quantify plaque burden we quantified plaque burden in these patients as less than 50%, 50 to 75, or more extreme 75%. And you can see it takes 75% plaque burden to actually see a decrease in the voltage-gated calcium channels. And then we have our lean versus our metabolic syndrome, pigs, and it's greatly reduced in metabolic syndrome. The other thing to appreciate, of course, is the variability, the greater variability in the human patients, simply because they are more variable than our metabolic syndrome swine. So calcium store release in the humans shows a really nice stepwise decrease in the SR calcium store with increasing plaque burden. And again, lean versus metabolic syndrome pigs show a big difference. So enter endolysosome calcium. And as a potential way to help explain the extracellular calcification that we've seen here. And I would say that I was a complete skeptic about lysosomal calcium control in these coronary arteries because we tried to image it years ago in our healthy pigs, and we just didn't really see it. So we thought, well, it must be in other vessels like pulmonary. It's widely known there in pulmonary artery, smooth muscle cells, and others. But so we just decided, well, we'll go to the truth, the tissue, and that's with some human tissue. Before I say that, let me introduce endolysosomal calcium a little bit better here by looking at this, what may seem to be a pretty complicated figure of all the different transporters. You've seen everything from the sarcoplasmic reticulum in the previous slides. A couple of points to make, though. If you look at the metabolic syndrome characteristics on the far left, there's a decrease in calcium pump, the sarcolemmal calcium pump and sodium calcium exchange, and that really is maintained throughout metabolic syndrome. I just want to point that out. But now let's look at the endolysosome there, more to the right, lower in this big obese smooth muscle cell, and it's really quite an organelle, such that it can have 500 micromolar free calcium within it, whereas sarcoplasmic reticulum is estimated to be about 200 micromolar. So they're small, but they have a large, basically a large store. There's a couple different calcium release channels. There's the 2-pore calcium 2 ion channel, which is calcium selective. It's activated by this TPC2A1-N there in the lysosome, or naturally by NAADP. And then the TRPML1 channel is, and TRPML channels are activated by MK6-83. The endolysosome also has the V-type vacuolar hydrogen ATPase, which makes it an acidic organelle, so it can do its job in autophagy, etc. And it also then that low pH drives the calcium hydrogen exchanger so that it can sequester calcium. Now, as I said, we didn't really see lysosomes by imaging with lysotracker in our pig coronary muscles some years ago, and so let's see if it does happen to exist in the real truth tissue here, and that is a human arteries. And so here you see a right coronary artery. It's splayed open, and in this particular case, this is an explanted from a heart, and it has minimal atherosclerosis. Just on the surface here. And so we used lysotracker in these particular cells, and we right away noticed that a lot of the cells were nice and smooth, as shown at the top. 90% of the cells had this kind of smooth morphology, but only 21% of those were positive for lysosomes with lysotracker. But it was a different story. There's 10% of those cells then roughly had blebs, the kind of blebs on the surface, and every one of those, 100% of those cells had really robust lysosomes, as indicated by lysotracker. So, and then we looked also in this this patient in the circumflex and the LAD, the left anterior descending artery. And you can see where the A is that they do have a substantial amount of atherosclerosis. And so, and this had an interesting story then with the lysosomes. Of those, we pooled the circumflex and the left anterior descending, and there was about 50% of the cells there that were really smooth. And yet they had lysosomes in 83% of those cells. And but of those that have blebs, and if you look in the lower left-hand corner of the image that I just put up there, they really have that's a really nice cell with a lot of blebs on it. 100% of those cells that have these blebs had also lysosomes. So the point is that they're really it seems to be more they seem to be more predominant in coronary disease. All right, so but now I'll come back to some healthy pig coronary smooth muscles. And so we wanted to image, functionally image endolysosomal calcium signaling in these. So in this particular image, you can see that they're in zero calcium for the duration of this, most of the duration of this protocol. 5 millimolar caffeine is applied. We get our typical transient increase and a lot of responders in this. And then subsequently, we added directly 10 micromolar of the 2-pore channel 2 agonist, and we get a response in every single one of those cells. So and so that clearly lysosomes are alive and well, and even in healthy pig cells. And then this next one was the even more important experiment where we just reversed the order, and so expose the cells to the 2-pore channel 2 agonist initially, and we get really robust increases in calcium, and this y-axis is greater than the previous slide. But the most profound thing here is that 5 millimolar caffeine, which we have used so many times, it had absolutely no effect here. You can see that the calcium is just decaying all the way during the exposure to caffeine. So our interpretation here is, as others have shown actually, is that these 2-pore channel 2s and lysosomal calcium release stimulates calcium-induced calcium release in a number of cells, different cell types. And so and very, very important is that we also tried the TRPML agonist MK6-83, and there was minimal response. And I'm being generous in that regard because there was no response in 51 different cells that we tested. So, to summarize some of this, we're studying neointimal calcification in the large conduit coronary arteries, and hopefully you can see my CR there. I think it's important to note that the endolysosome must be very closely juxtaposed to the sarcoplasmic reticulum to cause calcium-induced calcium release. And I say that because if you look up at the upper left, where we have the voltage-gated calcium channel in blue, we have for many years used high potassium depolarization, and it does not stimulate calcium-induced calcium release in these cells, even when the calcium levels overall are similar to what you saw in the previous experiment. And instead, the sarcoplasmic reticulum takes up that calcium. So again, the endolysosome and the SR must be very closely related. So there's some significant crosstalk, and that makes me postulate that there may be, I just put in there a transfer from the SR to the endolysosome, such that as the coronary smooth muscle in atherosclerosis, the calcium store is decreasing because it is leaking calcium out of it. And could the endolysosome be taking up that calcium to then signal in the progression of atherosclerosis? And we don't know that because there's a lot of other steps regarding fusion, exocytosis, et cetera, in this particular case. Again, minimal TRPML functional channels in these conduit coronary artery smooth muscle cells. Now, it is known that matrix vesicle excitosis is essential for vascular calcification, so there's a lot more to be learned in this step from the endolysosome to other organelles that would give rise to calcification. Now, I'm going to go over this very briefly here. With medial calcification is shown in a really nice paper by Bott in Penn Lanley's group, and because it's kind of the promise for pharmacological tools here. And in their hands, they're studying medial calcification, not neointimal calcification, and it's in a mouse model. But they show very nicely that there's early endosomes and multivesicular bodies that then will result in this calcifying nidus. And in their hands, it's TRPML1 that is the calcium release channel from the lysosome in these cells that releases calcium, traffics and causes trafficking of the lysosome, et cetera, and fusion with these multivesicular bodies to end up in degradation and thus prevent calcification. So it may be a totally different story in neointimal versus medial calcification. So I gotta wrap this up here. Overall then, how does dysfunctional intracellular calcium signaling in coronary smooth muscle lead to coronary artery calcification? And I drilled down to the endolysosome, and there's crosstalk of the endolysosome with the SR. It does suggest possible translocation of calcium from the SR. We've certainly shown that there really is an endolysosomal calcium regulation in these conduit coronary artery smooth muscle cells. So there's a lot to be learned there. How can we translate this science to cures? Well, nothing's perfect, but I strongly suggest we use models that mimic human coronary disease. And with that, I thank you very much for listening.
Mike, that was a wonderful presentation. Thank you so much. I just wanted to remind the audience that Ask a Question box is located there for you to submit your questions. So please, send them in. We'll try and address as many as we can in the next few minutes. And if we don't get to them all, we will forward them along to Mike and might have that available for you. Okay, I will jump to our first question. When you say 75% plaque burden, what exactly are you referring to? Is that the artery cross-section is 75% blocked by plaque?
The easy answer is yes.
Okay. Is there a difficult answer?
Short answer. No. It's 75% blocked.
Okay, great. Okay, our next one. I may have missed this when you were explaining, but can you explain what a bleb is and how that compares to the I think it was the smooth?
Yeah, that's a good question. The bleb is just it's sort of just a I was describing them as bleb because that's always what I've heard from others. So it's like a nodule. Imagine a nodule on it. I don't know if you can see my hands here, but if they're just like that, so that if you had a vesicle that budded with the plasma membrane and made kind of an arc on that. So, and you had a lot of those would be blebs.
Okay, that's great. Thank you. Okay, earlier you were talking about applying caffeine and comparing that response. How is the caffeine applied, and can you go into a little more detail about the methodology there?
Sure. So we have in the schematic that showed the microscope system, we have a constant superfusion of drugs across the cells. The cells are although they're freshly isolated, we put them on the microscope chamber, and they'll stick enough to the glass that they stay there, so we have a constant flow over it. And so all of our drugs, and we have several different chambers, reservoirs of drug, and we just turn a little dial that goes from one to the other, and so we switch from just a normal physiological salt solution to a high potassium solution, or in this particular case, a high caffeine solution that will hit the cells within about to a full concentration within about 30 seconds or so, and it's there for as long as we allow the solution to go and before switching to another.
Okay.
I hope
Great.
that answers that.
I think so. That was a little more clear. Thank you.
Mm-hmm.
Can you explain the how long your experiments typically would last, and if this is separate, the lifespan of the obese pigs that you work with?
So the experiments typically, as shown on one of these slides, we like to start off with pigs that are 6 months of age because they're sexually mature and their body weight pretty much plateaus, and then expose them, have them eat the atherogenic diet, and their body weight will increase. Lean pigs won't increase very much, but usually it's a 6-month feeding protocol to get enough of the atherosclerosis that we like to study. And we've taken pigs out as long as 23 months on the atherogenic diet. And I think all those pigs lived for that protocol. We do see some very rare spontaneous myocardial infarction in these animals. So it's really just been the 2 years or 23 months that we've taken them out on the protocol. If you want to know the overall lifespan, though, that's about it's anywhere from 12 to 14 years.
Wow. Yeah, 6 months to get the atherosclerosis seems really fast. Wow.
Well, they're on the super diet actually, so they have enormous cholesterol in the diet to really accelerate it. I mean, if in an ideal world, if we could use less and keep them for 10 years or something like that, that'd be great. But I got a feeling I'd never have a graduate student if I did that. So.
Yeah, that's a good point. Okay, we have another question. He says, beautiful work. There seems to be a tendency for calcification from the small vessels toward the large size mother vessel. What could be the mechanism for that difference in regional calcification?
That's a great question, and I'd really like to know that. And so could it be any number of reasons? I mean, there's the ion channels are different right away. So if let's just use, for example, is a lysosome involved at all? And could it be that it's that the conduits have the 2-pore channel 2, which will regulate lysosome function in those, but they don't have the TRPML. But there is other data. There are other data showing that the microvasculature has TRPML. Is there that difference that regulates the sensitivity to developing atherosclerosis? Just as an example, I really don't know.
Okay. Something to hopefully find out one day. All right, we have another one here. Why do you think the lysosomes concentrate into the blebs? Are they causing the bleb, or are they migrating there after the bleb is formed? I really like that word.
Yeah. That's another great question, and I would think that they're potentially involved in the blebs because lysosomes they can go to the plasma membrane. There are other vesicles that go to the plasma membrane for exocytosis. So it could be that the lysosomes are driving that the blood formation, and it could be other vesicles that are fusing with the membrane. I really don't know that for sure. The way to do that would be to image lysosomes with LysoTracker, because it's a dye that can be used in functional, live cells, and stimulate lysosome trafficking and see if it does go to the plasma membrane and form a bleb. So that's really a testable question.
Fantastic. Okay. Okay, we have one more question that just popped in. So, have you examined effective exercise training on endolysosomal changes in calcium regulation, blood formation, etc., in the pig or other model system?
No, but I would love to. No, seriously. I mean, we've determined the effect of exercise on the SR calcium store, and on for example, I didn't show the detail on it regarding the stocks, the spontaneous transient outward currents, and calcium and calcium sparks, and exercise basically normalize those in the pig. We've not done anything with lysosome, but that would be a fantastic experiment to do.
Great. Another one you can add to the list.
Mm-hmm.
All right, we're going to make that our last question. Mike, I just want to say thank you so much for your excellent presentation. It was so great to have you here with us, and I hope that you enjoyed yourself.
Thank you, I did, and thanks again for everything you've done for the to get this presentation going and all that. So, and thanks to the audience too.
Yeah, no problem. It was all you, really, at the end. So, great. Thank you.
All right.
Big thanks. Yeah, big thanks also to the audience here for participating. In closing, we hope you enjoyed this Inside Scientific webinar, produced in partnership with the American Physiological Society and the European Council for Cardiovascular Research, and we look forward to having you with us again soon.